dreams of peace, we long to sleep. We'll rest tonight. When you lay beside me, I know everything's gonna be alright tonight. Could have been stranded, but we made it out of that town, baby, just in time. All these years we thought we had it down, but it was just a foolish spray. It's okay, and it's alright. This graceful life.
Hello, and welcome to another episode of the interviews with Richard Windmann. I'm Richard Windmann, and today we have a very special guest, Dr. Ellison, Dr. Michael Ellison. How are you doing, sir?
Very fine, Richard. Happy to be here.
Thank you for coming and giving us your time. Can you give us a little background on who you are and what you do and your experience?
Sure. I started out in life as an airline pilot. That was kind of my first career. And then in my 30s, I transitioned, completed my PhD in psychology, and started working in the counseling field. And that was here in the local area in Fort Worth, Dallas. In 1995, I was recruited to Texas Wesleyan University in Fort Worth, where I've been a professor since that time. I was charged to create a school of counseling for professional counselors, and we opened our doors in 2003. And since these almost 20 years, we have been producing professional counseling graduates, licensed marriage and family therapists, and in 2014, our first class of PhDs in marriage and family therapy. So I predominantly teach the psychopathology and psychopharmacology courses in the master's curriculum. And in the doctoral curriculum, I teach neuroscience for counselors and psychopharmacology at the doctoral level. So I maintain a private practice and have all these years. The combination of professional practice and teaching has been a godsend. It really has allowed me to teach counselors, and of course, teaching hones your own clinical skills. So I'm still doing both jobs and love it every day. I, as part of my work, was asked to work with a police department back about 1990. And I worked with him as a volunteer for 10 years, and they as the crime victim advocate and crime victim liaison officer to the department. And in 2000, they asked me if I wanted to go to Police Academy, which is a one-year academy commitment, which I did in the evenings for a year. So I was commissioned as a peace officer and served for 10 years on active duty, predominantly on the weekends, which is when I saw so much of the domestic violence and the abuse that we're here to talk about today. From the perspective of crime victim liaison and from the peace officer point of view. Now, so having had sort of both sides of the street education, if you will, it has given me, I think, a broad understanding of what happens to victims of crime, and at the same time given me an understanding of what it takes to treat those persons who have been abused in certain ways. And I continue to do that work now. I'm no longer a peace officer, I'm retired, but I still serve as a consultant to several police departments in the area. That's kind of a longish answer for short question. I'm sorry.
No, that's fine. So it sounds like you're qualified to answer our questions.
Well, I sure hope so.
Okay, can you just to start out with, can you give us a high level understanding of what a victim of childhood sex abuse, or what, first off, what happens, and then how they matriculate through life?
Well, I want to start in those very first few years of life, because the brain is developing, and the brain cannot put language to memories until we are about 4 or 5 years old. And so we divide memory into explicit memory, those memories that we have that we can give words to, that we remember clearly, and implicit memories before age 4 or 5. Whereas the book title, The Body Knows the Score, or The Body Keeps the Score by Bessel van der Kolk, these implicit memories are stored in the body memory section of the brain. So many of the patients that we see who have a certain constellation of physical symptoms from early childhood may not actually remember what has happened to them, but they have certain characteristic behaviors of people who have had abuse. So there's one demarcation line, early childhood sexual abuse, often accompanied by domestic violence, as you might guess. Then the impact of that is that the developing brain, which really does not complete its development until age 25, the developing brain is programmed from these implicit memories to have certain, routines, brain routines, like a computer routine, to be, in some cases, hypervigilant, paranoid or suspicious, easily frightened, high levels of anxiety, and difficulty in relationships, all without understanding why these things exist. And so sometimes it's only when they finally get to a trained therapist do they understand the connection between implicit memory, early childhood events that they can't recall, then sometimes explicit memories of things that they can recall after age 4 or 5. And then these, I think of them as non-functional behaviors like paranoia, substance abuse, things that we eventually end up diagnosing perhaps as post-traumatic stress disorder. That constellation of symptoms to a trained therapist who's seen this before indicates that they need some trauma-informed counseling.
And what's the difference between, regular therapy, cognitive behavioral therapy, or DBT? What's the difference between that and a trained, trauma-informed therapist?
Well, it's interesting because those of us who were trained in cognitive behavioral therapy generations ago, now CBT has a trauma-focused CBT component. So you can be trained in specifically the cognitive and the behavioral manifestations of trauma and how to treat that using CBT therapy. And most other kinds of therapy, like dialectic behavior therapy, the DBT that you mentioned, have also had an additional training for trauma treatment to sensitize therapists and train them on how to do trauma work. So, and then there are other kinds of therapies that were designed to, in the beginning, deal with trauma, such as eye movement desensitization and reprocessing, what many people have heard of as EMDR, which was formulated as a trauma therapy from the very onset.
I see. So in my experience with the organization SCSA is that it seems almost without exception that survivors of childhood sex abuse have depression, anxiety, PTSD, sometimes dissociative disorder. Can you expand on that, or are there any additional co-occurring disorders that we might think about?
Well, Richard, it turns out you've named all the kind of the big four, but the one that I would add is one I mentioned just a second ago, is that many people are self-medicating their anxiety, their depression, their the effects of PTSD, the unwanted traumatic memories that are coming back. And they self-medicate with alcohol and all kinds of drugs, I think. It depends on the individual, of course, and that is to decrease their central nervous system arousal, to decrease that anxiety, to medicate those memories so that they're not constantly bombarded with those. For example, it's not uncommon for someone to, in their head, sort of see a videotape of the trauma over and over and over again, 24/7 for decades. And so for persons like that to stop the flow of that continual unwanted assault on them, getting drunk or high is a way to fix that. And so I would just add that we quite commonly see substance abuse issues around that. And of course that becomes problematic because the person may become addicted to those self-medication strategies, and then we have just another thing to deal with in therapy.
Yeah, my personal experience was the drugs never stuck, but the alcohol was my solution,
Yeah.
if you get what I mean.
Yeah.
And so, yeah, at SASA, what we see is, or what I've been able to put together, and again, I'm a layman, not a psychologist, is that they live in a world of misplaced shame and guilt, and therefore it's a secret, and you can't tell anybody, so you start self-medicating to deal with the pain, and when that doesn't work anymore, and it will stop working, suicide. Is that an accurate description of what they go through?
Unfortunately, sir, it is. And as we know from the current epidemic of suicide, as a mental health delivery system, we are failing at being able to help those individuals to avert those kinds of plans. And Texas, my home state here, is like 47th out of the 50 states for statewide support of mental illness services. So we have a lot of room to grow. We have a lot of room to expand and try to help people. So those are political decisions made at the voting booth, and we live with the consequences.
Yeah. The PTSD, does it present the same way in a victim of childhood sex abuse and the military PTSD? Is it same symptoms?
That's an intriguing question, really, and I want to make the distinction between trauma in a child's brain is experienced differently than trauma is in an adult brain. If you send a 20-year-old into combat, they already have a 20-year-old brain that's well-formed, and then you add trauma on top of that. Not that that's easy, but it's different than having a 4-year-old who's exposed to trauma with only a 4-year-old brain to draw upon. So they don't have any education, no maturity, no experience in life, no idea of how to sustain themselves independently. And so many times in children, we see what we call a trauma partnership in their brain, in that the offending person may be a caregiver. So they have this horrible fear of trauma from this caregiver, and they must also at the same time find some way of negotiating a relationship with this caregiver, because their lives depend on that person. So if mom or dad is the offender, they have to both love the offender and they have to suffer at the hands of the offender. And that is not the dynamic that we see in PTSD, for example, in military personnel or someone who's sexually assaulted as an adult. So it's sort of an apples and oranges consideration for therapists. Now, maybe to the general person, it seems very similar, because PTSD symptoms have a similarity in all persons, which we could go through if we need to. But I see these as very different disorders because of the age of the person when they were traumatized.
Interesting. So at SESA, we at SESA we recommend a holistic approach. So medication, trauma-informed therapy, and fellowship. And in fact, that's the SESA function, peer-led support groups. We recommend those three for them to start their healing journey. What would you say to that? Are we doing it right, or something additional that we can do?
Well, I think you're doing it right. In fact, I want to say congratulations to the peer support network system, because I think that's the thing that's generally absent in outpatient psychiatric care or in outpatient trauma care, is that peer support group is very powerful, a very powerful agent for healing. And that's just not possible in most cases for patients to take advantage of. And so I think that the peer support, in addition to these other elements, is very likely to be one of the things that your people find most helpful. There's just nothing like sitting next to somebody else who has been in your shoes, and they can take your hand in a tough moment and say, you can get through this. If I can get through this, you can get through this. And so it makes that traumatized brain, if you will, not socially isolated, but a part of a social community that's had a similar experience. And I would be remiss if I didn't mention that this is the peer support model, although I think in the military counseling system it's also professionally led by a mental health counselor, but the group is largely composed, if not strictly composed, of peers who have PTSD, and the military finds that this is the model that they want to use. So I think there's some evidence that this is really quite helpful.
Yeah, the way the way that I describe it is, in Alcoholics Anonymous, they know that if you master all 11 steps but don't master the 12th, you will drink again. And we don't make people do step work, but it's basically the 12th step, service to another. And our support groups are extremely powerful. We've had people come in and share their story the very first day. We have people that hang out for a couple of weeks before they even say anything, and it's an incredible safe space. Trust, as you know, is a very rare and valuable commodity in the survivor world, and we've developed this group. We we don't do co-ed groups. The sexes are separated, and it's just magical, some of the things that happen there. Any more thoughts on peer-led support groups?
I have a long history of providing care in psychiatric hospitalizations, and have conducted in excess of 5,000 hours of group psychotherapy in psychiatric hospital settings. So I feel like I can speak with some knowledge of the power of peer support to change and to change not only our belief system and our behavior, but there's increasing evidence from the neurosciences that the peer support system and disclosing self and having others disclose themselves and sharing information changes the way the brain structure forms and how the brain functions to the benefit of the participant. So I think that not only do we have the anecdotal information between you and me and how that peer support group helps, but we also have solid physiological data that shows peer support systems change the brain for the better. And I think that everybody that studies peer support effectiveness comes away with the conclusion that however imperfect we are as humans, this is a winning combination for psychotherapy.
Thank you for that insight. So I read the DSM-5. Not all the time. It's very dry reading, but
No cartoons and no funny pictures. Yeah.
no, none at all. And it does a real good job of articulating all these disorders, but it doesn't spell out a cure for any of them. So is this something that we're going to die with, and we just have to find a way to manage it, or is there a cure?
Well, DSM-5 is written by and for psychiatrists and other providers of medication. So they're prescribers, and the book is written for them. For counselors, DSM is something we have to negotiate. It's the quote-unquote Bible of diagnostics, but it does not talk about treatment anywhere.
Yeah.
And so what we're left with is a plethora of psychotherapies that are being used, at last count, over 400. Different kinds of psychotherapy are being applied to all the diagnoses in DSM worldwide. So if we were to look at therapy books and how to do therapy, even if we addressed the top 20 therapies worldwide, it would be a huge volume. And to treat trauma would be, I think, a big part of that ideal volume of treatment. DSM tells prescribers what to look for so that they can give appropriate medications, and that's valuable. Mm-hmm. I'm not a physician, but I would presume that was quite valuable. But for the other psychotherapists, there's precious little indication, save trauma-informed, quote-unquote, therapy treatment. There seems to be a lack of an indicator that says this is the best therapy for trauma. for this age group or that age group or this person or that. So I think that if we were to try to look towards psychiatry to talk about what is the most effective psychotherapy in something like a DSM, I don't think we're going to see that. I don't think that's been, and I don't think that will be. We're looking in the wrong place.
Do you think that the DSM will ever recognize CPTSD?
You know, what I have discovered in my career is that the DSM, the so-called Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association, is a reactive piece of work. It's reacting to the pressures of the marketplace and the political pressures that and the research pressures that say we have enough research information to say this and we don't have it about that. Those of us who work in the treatment community talk about CPTSD or complex PTSD as an established fact in our work, but whether that will ever show up in DSM, I'm really hesitant to say, because there's been substantial work by the psychiatrist from Netherlands, the Van der Kolk, and others, that show that the complex version of PTSD is not only a physiological fact in neuroscience, but is also evident in the counseling room. And so to have the blessing, if you will, of this American Psychiatric Association group, which is reactive to political pressure and maybe not even would change the diagnostic schema that they prescribe with. So I think there's very little push to have the psychiatric community in particular to say, oh yeah, well there's this kind of PTSD that we see in certain individuals that's even more complicated than PTSD is, by the way, and we want us to all be aware of that, and it may or may not change your prescribing policy, but you should be aware that this is so. I think that's going to be a long struggle, frankly, to get that into the DSM if there's any push for that.
Okay. So what I found is really effective for me, and it probably saved my life, was ego state therapy is both a primer and an adjunct to EMDR therapy. Can you explain why those two therapies work together?
Well, I think, first of all, it requires us to kind of define both of what we're talking about for the listener. You and I and everyone actually have different parts of ourselves that take different directions from our world, and by that I mean, I can use my own life as an example. As I said, I was an airline pilot for many years, and so there's a part of me that's an airplane driver that if you put me in an airplane, I'm at home and I'm ready to go to work. But I haven't done that in 20 years. I'm retired. So does that mean that part withers away and is gone? No, it's still there. It's just maybe a little rusty, but if I needed to, I could knock the rust off and I could go flying again. Mm-hmm. Well, we all have parts like that respond to the environment in which we live. And particularly in therapy, and particularly in the therapy treatment of childhood sexual abuse, the brain does a very creative and imaginative thing in that it creates a part that can remain apparently normal to the outside world an ego state or another part that handles these complex emotions, some of which we have talked about in this recording. Mm-hmm. So these emotional parts sometimes handle the difficult, painful memories that the apparently normal part is not able to deal with. And the life of these emotional parts persists just like my airline pilot part until we either heal or die. And in my work as a therapist, it's not at all uncommon to see people in their 30s and 40s and older who are just now beginning to deal with these emotional parts that were created in childhood by this very creative act, and to preserve the capability to get by in apparently normal ways. And it relates, I think, to the part of the conversation we had earlier that talks about this child who has a traumatic partnership with a caregiver who must depend upon that caregiver for some element of their survival, and that same caregiver is one of the perpetrators of their abuse. So that this creative split can persist, and EMDR therapy, which was designed to treat trauma, directly addresses these emotional parts using ego state therapies that slightly modify the EMDR protocol to address these emotional parts and include them into the apparently normal parts to allow the person to more fully appreciate both the horror and the help that EMDR can bring to them. So I think that there are other therapies that are designed to integrate personality, but I'm not sure that any of those therapies does it any better than EMDR would. For example, I was a hypnotherapist for decades and did this same work using the hypnotherapy protocols that existed at the time. And yet, when I finally took EMDR training, which was about 10 years ago, I've been certified in EMDR for about 10 years, I found that it was much more effective than hypnotherapy for treating the same patients. And so I have largely let hypnotherapy slide to the side and have focused on EMDR as the predominant therapy modality that I use to treat trauma.
Are there any modalities or therapies that we don't know about? Anything that's emerging that you think has promise?
Well, that's an intriguing question, because in the past few years, we have seen the use of magnets placed around the brain for transcranial magnetic stimulation, and that science is beginning to produce its first peer-reviewed articles regarding its efficacy and effectiveness. So I see that transcranial magnetic stimulation is probably a modality that is going to grow over the next decade or two as they solidify their research base and as we get better neuroimaging from the patients that undergo transcranial magnetic stimulation. So I think that that's a very promising avenue, and there are other kinds of neuroscience-based treatments that are coming to their own by, and I think, I just would like to say that I think almost all of those treatments start with the idea that we have to demonstrate scientific effectiveness or we're not going to be able to go anywhere. So I think that whatever new therapy or therapies come down the pike in the next however long, the idea that we can demonstrate a change in the brain as a result of this therapy is going to be the standard to which we are all held.
And how do you tell that, though? Just, regular brain imaging or CAT scans or MRIs or?
Well, and that's a good question. And there are those, the CAT scan, the MRI, and other forms of like functional MRIs are currently available, but there are new neuroimaging technologies appearing every month. And so where I remember very clearly, Richard, in the late 1980s, they said, okay, you guys, 1990 is going to be the decade of the brain. And so there was all of this emphasis on brain research. Places got funded to do research that hadn't been funded before. There was this worldwide emphasis on neuroimaging, neuroscience, neurostudies. And it took arguably until 2005, 2010 for all of that elemental research to filter down through the review systems and get published in the literature and find a toehold in the treatment community. Mm-hmm. So we're seeing that same thing happen now, but it's in a much, much broader domain, in my opinion. We have better neuroimaging to start with now than we did in 1990. We're able to perform chemistry analysis that we weren't able to do in 1990. For example, in 1990, we knew precious little about Alzheimer's dementia. Now we have a reliable blood test for Alzheimer's. This is maybe to some 30 years too late, and I understand that that's a long time to wait for that much progress, but it is progress and it's happening. So I say to people when I teach my students, this is the future of psychotherapy, is brain imaging and brain imaging analysis. And it shows quite remarkably that the power of our words in the counseling room can change belief systems, which change the functional structure of the brain, mm-hmm. which change the brain's chemistry. So people say, "Oh, talk therapy, that's just talk." Well, I guess on some level that might be true, but on a more profound level, talk therapy changes brains. And when we're engaged in talk therapy in the counseling room, the therapist and the client exchange brain information, if you will. There's a great book about that, Right Brain to Right Brain Therapy. Mm-hmm. And combining neuroscience approved and tested strategies with talk therapy is a very powerful way to change people and has a really an incredible future to come, I think.
Wow. Okay, let's buckle up. We're going to leave the reservation, go into the Wild West. This has been gaining popularity, I guess is the best way to say it. And there's been some studies that have been approved. What do you think about psychedelics to treat childhood sex abuse survivors?
Well, this is an intriguing notion to many people. As a person myself, I love to look at archaeology research, and an altar was discovered in Israel that they dated to 8,000 BC. And on the altar, the burnt remnants of the substances used at the altar were analyzed, and cannabis or marijuana was noted and has been used for the past 10,000 years. The native populations have used psychotropic or psychedelic plants and herbs for at least that long. There is an ancient history in healing arts of the use of psychedelics to assist people to, in a word, to see God. The neuroscience information is so powerful in the case of the animal tranquilizer ketamine that it has been licensed to be used in the treatment of depression, and it has psychedelic and hallucinogenic properties. Yeah, sorry.
You thought we were going on a commercial break. I didn't know about that.
The latest information that we see in the use of psilocybin mushrooms and in other neurotropic medications or substances like this show that they have medicinal long-term effects on the brain. And the research that we have been able to see in recent years has said this helps the brain talk to itself in different ways. And that helps, for example, in depression, that the latest research from a couple of weeks ago released that psilocybin has a durable long-term effect on the way the brain talks to itself, a concept called brain connectivity. It changes the way the brain talks to itself, alleviates some of the symptoms of depression. I think that this may, they say that everything old is new again, and I think here we are coming around 10,000 years later, and now we have the science to say these ancient healing arts have a basis in science, as it turns out. So I wouldn't be surprised to see what we now think of as psychedelics or neurotropic active substances to become medically authorized and legalized and in practical use. They seem to work.
Yeah, I've personally, I've tried DMT, I've tried mushrooms, and it's great, but the efficacy only lasts for about a week or two. And I'm about to go on an ayahuasca retreat to see what that's about.
Yeah, I've had patients who've used ayahuasca, and I went to the Amazon rainforest back in the 80s and watched this in native populations, and did not participate because I just thought that was probably something I should observe and not participate in, But the ayahuasca is DMT, and we have experimented in the 1960s. When I was a college student, I remember I was a residence assistant in a big residence hall, and there were people using all sorts of hallucinogens at that time. And so I saw a number of people under the influence. And I think what's different now is that they are therapist facilitated psychedelic use, so that there are parameters of safety and dosing and stability of environment, not contaminated with alcohol or any other kinds of substances, which was common back in the 60s. Kids would be using cannabis, alcohol, DMT, a plethora of...
At the same time.
Yeah, all at the same time. And so there were too many confounds as to which variable was working and which was not. So I think nowadays those confounds have been largely eliminated. We have controls, and we have individuals that are experienced and trained in helping make that experience probably what it was like 10,000 years ago when shamans helped people to, quote unquote, find God in their spiritual lives by using these substances. I suspect that's kind of what happened all those years ago, why it was thought of as a holy sacrament 10,000 years ago or more.
Mm-hmm. So, let's see. Is there any benefit to a survivor? Well, first off, we'll start at the beginning. So the way that we categorize folks is there's victims who don't say anything, don't come forward. And then when they do reach out for help, any kind of help, we consider them survivors. And after they've been survivors for a while, some of them do become advocates. Right? But if they don't, we call them warriors, or the ladies like to call themselves thrivers. Yeah. And is there any benefit to a survivor to cross over the next line and become and to tell their story publicly? Is there any additional benefit, do you think?
Well, I think there is, actually. And I think I would like to use the case of males who have been sexually abused as children, who those of us in the treatment community know that trying to get males to get treatment, to talk about what happened to them, is like proverbial pulling teeth. We have some pretty good information that about 1 in every 6 males was sexually abused as a child. We have a paltry number of men who've come forward and said, this has happened to me. When we look at what happened in females with their ability to say, I have survived breast cancer, and you should get tested too, the female community responded en masse and got huge numbers of response, and continues to this day. The March for Pink and all of those things that we are so familiar with started because a very few, very brave survivors said, this is important, women, you must do this. And it's been a benefit. Millions of women's lives have been saved because of this, I think, heroic coming forward decades ago. We haven't had that same phenomenon happen with men in prostate health, nor in male sexual abuse and sexual abuse survivors. We desperately need men to come forward, men that have a high profile. You know, if I came forward and said something, it wouldn't matter. I'm just a little fish in a little pond. But if a Hollywood celebrity came forward and said, this happened to me, and you should, if it happened to you, you should go talk to somebody. Oh my goodness. I can't help but wonder how many men would benefit, how many children of these men would benefit from having that experience in their home, of seeing someone go forward and do a very courageous thing and get help, because men are not willing to do it.
Oh, that's for sure. Here's another demographic that's got me confounded currently, is in the African American community. So, for example, in our organization, we have over 1,300 members. There's only one African American in the male group. So, why is that?
Well, that's a really good question. I am not African American myself, and that statistic that you cite is just appalling evidence of the very thing that we're talking about right now. Is that if sexual abuse in the male community is marginalized and not discussed, then in our community of racial inequality and discrimination and prejudice, it, I think, has multiplied the effect of keeping silent, so that it's almost impossible to get this kind of information forward and into all communities.
Wow. Would you characterize childhood sex abuse a form of menticide?
Talk to me about what it the word, for our listeners' sake, what does that word convey to you? What if you were to define that to someone walking up to you on the street, what would you say that is?
So for me, what it means is somebody just kills your brain, kills your soul, everything about you. It's consuming.
I think those of us who work in the treatment community would say that we are composed of mind and we are composed of body and something called spirit, whatever that might be, however that's defined by the individual. It could be religious or it could be non-religious. It could be emotional or anything else, but it's not mind and it's not body, but it's something else. And if we as treatment providers ignore that third component of disorder and only treat the mind or only treat the body, we've left a third, and maybe arguably the most powerful third of our personage unaddressed. And we see in persons who are victims or survivors, or maybe even, as you say, thrivers, we see that spiritual damage in a way that cuts so deeply that I try to make sure that in the therapy that I do, that in some fashion or other, we address this, because if we don't, then the long-term sense of worthlessness, the sense of lack of meaning, I think promote that suicidal thinking that we're trying to combat. And as I think the result of not being able to address that spiritual component. So I think if you mean by menticide that third spiritual component of person, then yeah, I think that we fail to mention that at our peril.
Interesting. Wow. So I read a study out of Stanford University, and they suggest that there's 4 million people in the United States right now that haven't come forward about their childhood sex abuse, that they still suffer in silence. Do you have any confidence in that number?
Well, just off the top of my head, I think it's far too low.
Yeah, I agree.
And so what I know from the statistics from the local rape crisis center in this county in Texas is that 38% of women are victims of sexual abuse, half of those victims before the age of 14. So if you extrapolate from the population of this county and those numbers to the population of the entire United States, 4 million doesn't even touch the number of victims in Texas, much less in the other 49 states. So I think it's more likely that we're looking at maybe 30 million women in the United States that are victims of some sort of sexual abuse or malfeasance. And if we say 1 in 6 males, and if we use that figure, then we can add to that another 8 to 10 million males. So you can see that these numbers together, we're looking at maybe 40 million people, not 4 million people. We need much, much more in the mental health field than we currently have. We need more providers. We need, of course, more of everything to do our work.
Right. Would it be fair to say that victims, they pretty much live in their amygdala?
Well, let me talk about that for a moment. So, to the listener, the amygdala, just for education purposes, is a small almond-shaped structure, and there's one in each hemisphere of the brain. So our brain has 2 amygdalae. And these are the threat detectors of our brains, and they never rest. So the one in the right hemisphere is aware of our social setting, the people that we are around, the situation that we are in socially. The amygdala on the left side is not so socially functioned. Once the threat system has been activated, and by something like sexual assault, that would be, as any person might understand, enormously activating of our threat system, then that threat system changes the rest of the brain's chemistry and function so that it's hyper-focused on anything that resembles a threat in the future. If this happens in childhood, then it changes the way the developing brain develops between then and 25, so that formalized structures of the brain are focused on this threat. And so we get people who are paranoid, suspicious, and hyper alert to anything that looks or resembles a threat. So is it right to say that victims have a overactive or appropriately active amygdala and alert system? And it's hard to say that that system shouldn't be alert because they have been hurt horribly. And for us to say outside of them, oh, that system is too, we need to turn the volume down in that amygdala system, we don't have the right to say that. That system has been designed to keep us alive. And we turn the volume down, if you will, at our peril.
Wow. That's intriguing. I never thought about it from that perspective. So basically it releases cortisol in the body, and that compromises the immune system. Do you see in your patients that are your trauma patients that, maybe they have more physical ailments or aging a little bit faster than they should?
Well, yeah, and I think we see that in the national data from the Adverse Childhood Experiences study called the ACEs study that was done in the late 90s. So that data has been available for a little over 20 years, and we look at physical abuse, societal neglect, and the third component is loss of attachment through imprisonment or of caregivers, etc. So the researchers that did the ACEs study were able to say, when we look at this information, and they had 18,000 people in their study, when we look at this information, we see a 400% increase in suicide, we see a 1,200% increase in lung cancer, etc. We see physiological and psychological disorders way, way above our national average from these adverse childhood experiences. So I think there's plenty of physiological data that indicates that trauma is the horror that keeps on horrifying us, body and mind.
Wow. I have a question from one of our longtime members. His name's Nathaniel. He's in New York, and he wanted me to ask you, what's your definition of God?
Well, I appreciate Nathaniel's question, and I'm not a theologian or a seminarian. I'm just a psychologist. But I would say that part of that mind, body, and spirit that I talked about before, part of that is that spirit component is the spirit in you, the spirit in me, the spirit in all of us. And where that came from and how that manifests and where it goes after we die, or does it die with us? All of those intriguing questions I'm unable to really answer, but I can say that if I see you and you see me and we each acknowledge that we have that small little component of spirit inside us, then we would honor each other in a way that we probably wouldn't otherwise. You know, we wouldn't do violence to one another because it would be doing violence to ourselves. If we really respected the spiritual component of each person, we would treat each other differently in this world, and I think that's what we all hope for.
Okay. So, your audience is victims and survivors. Well, say victims. What would you tell them? Mike's yours. What would you tell a victim of childhood sex abuse who's struggling?
Well, I understand that any kind of experience like this and the aftermath would lead to a struggle. This is not a phenomenon that can happen to us with no consequence. Every person that I have seen in my practice has wrestled in their own way with the aftermath of this phenomenon. It's very common, but it's outside the range of our brain to handle it. We aren't designed to handle this kind of trauma and abuse. It's really outside the range of normal human experience. And so it is by definition an abnormal and unfortunately all too common experience. And so every person who struggles to put their life back together has my support, and never more so than those persons who sit in my office and say to me, I think my parents were abused as children. My parents abused me when I was a child, but I have sworn that it ends with me, that I will not raise my children in this horrible way. And I am going to end this legacy of abuse and neglect with me. It ends with me. And the next generation that I raise will not be encumbered with this horror. And I can't think of any person's more courageous than that.
Oh. Well, thank you for your time. We're at the end of the show now, and for the listeners, I'm at Dr. Ellison's house. He has a studio in the back of his house, and we've been having a good time talking. And is there anything else that you want to add before we end?
Well, I would like to say to those 1,300 people in your groups, I'm so grateful that you have found each other, and I wish that you could multiply your efforts 1,000,000 times over and find even more survivors and help them along. And I wish you the very best from my heart.
Thank you so much, Dr. Ellison.
Thank you, Richard. Bye-bye now.
Bye-bye.
It's okay, and it's alright. Don't get up, baby, I'll get the light. This graceful